welcome to a final response to COVID-19. This online event is one of our very final events at Science Gallery Dublin, so it really is the end of an era. This recording and most of our online content are available to view retrospectively on our YouTube channel. So if you miss our programming, then please do have a look at our YouTube and check what we've been up to for the past 14 years. So back to the event. We are now 2 years into the COVID-19 pandemic, and despite NPHET's latest announcement, COVID is still very much present today. So we have assembled the full panel from our early rapid response to the novel coronavirus from January 30th, 2020, before we ever even thought that this pandemic would actually happen. So today we have Maria Delaney, Karina Butler, Cillian de Gascun, David McGrath, and Nigel Stevenson. So thanks so much for joining, and I'll hand it over to Maria.
Thanks very much, Jane. So I'm Maria Delaney. I'm an investigative journalist with Noteworthy, and obviously I was a science journalist before that, so I'm very familiar with Science Gallery events, and sad to see that this is one of the last ones. But in terms of this event, so we were here at the very start of the pandemic, over a month before the virus officially arrived on our shores. And now, given the government's easing of restrictions last week, though cases are still prevalent in the community, many are talking about an end to the crisis. And at the weekend, even the World Health Organization's European director said that this region could be moving towards a pandemic endgame, though the Director General of WHO was quick to point out that that might not necessarily be the case in terms of the end of the pandemic. Unfortunately, there have been many more cases than the 7,700 we reported in our first event, with over 340 million to date, resulting in over 5.5 million deaths across the world. And last year, hope was on the horizon, with the European Medicines Agency approving both Pfizer and Moderna the month before we met, and AstraZeneca later in the afternoon following our talk. And this is the final event, as Jane said, in what has become a coronavirus series, with the same panelists looking back and reflecting on the past year, as well as thinking about the months ahead and perhaps the years ahead. And I'm joined by Dr. Cillian de Gascun, who is Director of the National Virus Reference Laboratory and Chair of the NPHET COVID-19 Expert Advisory Group, Dr. Karina Butler, who's a Clinical Professor of Pediatrics and Infectious Disease Specialist, a retired consultant pediatrician and Chair of the National Immunisation Advisory Committee. Dr. Nigel Stevenson is an Assistant Professor in Viral Immunology, and Dr. David McGrath is Director of the College Health Service at Trinity and is a member of the College Working Group on COVID-19. So I'm going to start where I started for the past 2 years. So Cillian, just going back to where it all started, I asked you about the hunt to figure out where the virus came from. And last year, a team of WHO scientists investigated this, and there was also a different investigation by the US intelligence group, which came to the consensus that it was not developed as a biological weapon. But have we actually figured out how it arose yet?
Thanks, Maria. So no is the short answer, I think. We know that there are hundreds of coronaviruses in bats. So we believe the ultimate source of the virus was and is a bat. But the problem is we still haven't figured out whether there's an intermediate host, and if so, what that intermediate host is. And I suppose that's a concern for us in the context of trying to prevent future spillover events. If you remember back to the original SARS coronavirus outbreak in China in 2002, 2003, when the intermediate host in that setting was first identified, there was a massive cull in the live animal markets of palm civets. And the fact that when the animals were reintroduced and the virus reappeared actually gave us a clue in the context of the fact that they were an intermediate host rather than the ultimate source. So to me, as a virologist, I think it's still an important piece of information to try and figure out where and how the spillover event occurred. What's interesting in the context of Omicron actually is that its spike protein is capable, or more capable than Delta and other variants, of utilizing other animal receptors. So while Omicron to date has been less severe, the fact that it's slightly more, what's the word? I suppose slightly less exclusive in its binding capability means that it increases the risk of a reverse zoonotic event, whereby this virus could become established in an animal reservoir and then could continue to evolve in that setting and spill back over into the human population. So it's still something that we need to really be careful of and keep an eye on. So unfortunately, no, we don't know where this came from, but I still think it's important that we try and figure that out in the context of the laboratory accident scenario. There's really no evidence for that. And in fact, the way SARS coronavirus type 2 initially was designed, you probably wouldn't have designed it that way if you were trying to develop a particular virus for human pathogenesis or sort of for human infection, purely because you'd probably build on the likes of the original SARS coronavirus or learned from MERS, and SARS-CoV-2 really didn't do any of those things. So I said with no real evidence to support the laboratory incident, but unfortunately we don't yet know in the wild where it might have originated.
Perfect. And I suppose just speaking about transmission there, because you mentioned Omicron, Nigel, just in terms of science, one of the areas where this virus seems to constantly surprise experts is transmission. And new variants are presenting scientists and healthcare professionals with constant challenges, such as how Omicron is so transmissible in the air. So Nigel, can you tell us about what we know now in terms of immune response and infectivity?
Yeah, so back in November, we identified Omicron. And I suppose the most important thing with Omicron has been that it's mutated in about 50 of its residues. And the most worrying part was that Omicron actually mutated over 30 times in its spike protein. And the spike protein, as we go back to 2 years ago, we were learning about coronaviruses, and the spike protein is on the surface. It's this protein that sticks out of the virus and makes it look like a crown effect. And that's where we go with the word corona being, I think, the Latin for crown. And so if this spike protein mutates and becomes more capable of binding to our receptors on our cells, then it's more likely to actually infect us. And that's what we've seen with an Omicron, that it actually can get into our cells more readily. The other thing we've seen with Omicron is that it actually can replicate quicker. So some studies have shown that it's even 70 times quicker at replicating. So you're making more virus. The other thing that potentially makes it more infectious is that we've seen more of it in the saliva and our mucus. So if you're coughing or blowing your nose or spluttering or putting it into the air, then it's more likely to infect people. And maybe we're still talking about if we touch our nose or our mouth, and then we touch a surface, and then somebody else touches that. If there's more virus in our mucus and our saliva or our fluids, then that's more likely for somebody to pick it up and touch it and then put it into their nose or mouth and be infected. Another thing that people may have noticed, however, we were just discussing there a moment ago, this is only 2 months since Omicron really emerged, but we think it may have more incidence of asymptomatic infection. So basically, there may be a likelihood that more people have it and they don't know they're infected, and therefore they can go on and pass it on. So these are all things that have evolved. The good thing is with Omicron, it's not any more deadly, we don't believe. And we believe also that it infects the lungs less than Delta did. So it's not making people as sick. However, this is still a potentially deadly virus. And it's not just a bad cold. You know, this is something that we still need to keep thinking about. And also we need to be aware that viruses mutate constantly, and there may be a mutation to something that is more deadly in the future. So
Perfect. And I might bring David in just because you mentioned asymptomatic transmission, Nigel, and near the start of the pandemic, asymptomatic transmission was deemed unlikely. But last year, David, you were involved in a project, Trini Screen, on asymptomatic transmission. So I was just wondering maybe what you found from this, and yeah, if you have any results from the students on this.
Yeah, well, I don't really have any results that are going to be very instructive because, in fact, our uptake on the project was much poorer than we had initially hoped, and trying to identify asymptomatic transmission became very difficult. But other studies have shown that asymptomatic transmission has been, very prevalent, and clearly with the numbers of positive cases of Omicron. Not all those people were symptomatic, and clearly Omicron, asymptomatic transmission in Omicron is very common. It's very difficult for us to assess that because we're using different measurement tools now than we were using, say, 3 months ago, where people who were symptomatic or people who were close contacts had a PCR test. Now we've moved into the realms of antigen testing, and antigen testing instead of PCR testing for everybody in the country who's between 4 and 39 if they're symptomatic, and also antigen testing for close contacts. And these results are self-reported as opposed to the reports being automatically generated from the laboratories. So it's become much more difficult to interpret the data around case numbers and transmission than it had been previously. Even on campus here, we've had a HSE collaboration between ourselves and the HSE, and we ran our own testing centre on campus at College Health from September 2020 until just before Christmas. But in reality, it doesn't really make any sense for us to run a testing centre in university now if there are no PCR tests for people between the age of 4 and 39, because that's our cohort, our age cohort. So it has become more difficult for us to really get a handle on what's happening, and we're very much dependent on self-reporting by people, particularly with the new guidance on antigen testing for close contacts as well, and also because we're in a situation where we could potentially have very large numbers of people in confined internal spaces such as lectures, 300, 400, 500 people in theory. It's really important for us to know whether we have significant breakouts. We had a very structured reporting system in all the schools in the university, reporting into a COVID reporting line that I managed, and it gave us a great sense of what was happening around the university with students and staff in terms of positivity and where positive cases and where there were outbreaks. And we had very close working relationships with public health around the management of those outbreaks, particularly in accommodation. We were able to limit the impact of those outbreaks really through a combination of having the testing centre on site and having such close working relationships with public health. So I think it's going to be more difficult going on to really know where we stand with regard to Omicron. And also I think that, the testing centres not being operational in the way that they were is fine at the moment, but we really still are not sure. We really don't know what's going to happen, and we have to be able to pivot and have the staff that are in those testing centres available should we have another variant, which is, I defer to everyone else on this call around the likelihood of variants, but clearly COVID has not gone away, coronavirus have not gone away. There are likely to be variants, and in terms of responding rapidly, if the staff in the testing centres are already redeployed back into mainstream healthcare, it would be difficult to respond quickly. So
Perfect. Yeah, no, I might bring Cillian in on that point, just as director of the National Virus Reference Laboratory. Obviously, you're hugely involved in the testing capability, Cillian. I was just wondering if maybe you can just talk a little bit about the changes in testing, and as David mentioned there, just the impact perhaps on tracking the virus.
Yes, well, I think obviously people will be familiar with the way capacity has built up over the last 2 years from what started off about a capacity of about between 30 and 100 samples a day, and now at a national level, we're up to about 35, 36,000 from a PCR perspective, and then additional antigen testing on top of that. I guess the thing for us from a pandemic response perspective is to figure out when you transition from trying to identify every case to more of a surveillance system where you're doing enough testing to inform you as to what's happening in relation to the virus in the community, but you're not necessarily in that containment phase of trying to identify every case anymore. Because to be honest, that's not a great use of finite resources at this stage in the pandemic, when thankfully we have a huge proportion of the population vaccinated. And obviously the majority have also now had a third dose as well for their 2-dose regimens. So what we need to do is, as David has pointed out, is make sure that we're in a position, even though we've reduced the amount of testing we're doing on a daily basis, that we still have enough information and data to guide our public health response. So there are a couple of ways we can do that. Obviously, we have a sentinel surveillance scheme for, say, the likes of influenza every year. We have a sentinel program through our GP in association with our GPs and the Health Protection Surveillance Centre. So that has been COVID piggybacked on that through the course of the pandemic, and it's been very effective. We're obviously testing people as they're admitted to hospital. So we've identified a lot of infections that way, in addition to people who are admitted because of COVID. And then obviously we have surveillance in our ICUs. The area that we're probably missing is people that don't engage for care. So as David has alluded to, those people with very mild infection or asymptomatic infection, and therefore don't feel the need to attend to their GP. And that's the group that we're working on at the moment, and how best to tackle that. Obviously, the UK has been doing ongoing surveillance at the population level by distributing, by testing a proportion of the population. I think it's every, Karina might correct me here, but I think it's every 4 or 6 weeks or something along those lines, just to see how much infection is out there. We don't have a program like that yet in Ireland, but I think it's something that we will be working on. Work is ongoing at the moment to figure out how best to do that, purely because really the only way we can manage the demand on our health service is by knowing how much infection is circulating in the community. And as I said, we have some strands in relation to that. We obviously have wastewater surveillance as well, which is useful for telling us what's in the community, but I'm not yet aware that there's a simple metric for converting that into how much is in the community. So there's a number of different surveillance strands that we really need to get in place before we completely move away from the mass testing that we have been doing. There's still a significant level of demand in the community for testing, but it's certainly dropped off dramatically over the last week or so. But I think moving into a surveillance program or surveillance mentality is really the next challenge for the testing program.
Perfect. And Karina, I might just bring you in just about, like last year we spoke about controversy over children and transmission, and you had mentioned that children don't spread it as efficiently as older adolescents or adults at the time. And I was just wondering, like obviously controversies over children haven't gone away, with issues raised over whether the virus is spreading in schools, especially in the last term, and with more cases being reported in younger people towards the end of 2021. So I was wondering, what do we know when it comes to children transmitting the virus, and has this changed with new variants?
Well, you're absolutely right in that children generally don't transmit the virus as effectively as adults, or certainly children as effectively as unvaccinated adults. But a number of things have changed over the time since we last spoke. First of all, the majority of our adult population, amazingly in Ireland, are vaccinated. And not only are they vaccinated with 2 doses, but again, slight majority are vaccinated or up to date with their boosters as well. So that impacts the likelihood of adults to transmit disease. And then the second thing is we've had the arrival of the Omicron, which is more easily transmissible. And yes, children can transmit, but we're probably seeing more the impact of children who transmit because the other part has been taken out of it or reduced, and we have a more transmissible variant. Thankfully, it still remains in the most part, a mild disease of children. And we know in the preceding waves, however, that children could get severe disease, either primary viral pneumonia, which is very rare in healthy children, but even in those with mild infection or asymptomatic infection, they might later present with the inflammatory syndrome, the sort of what's called PIMS or MIS-C. So it's a multi-system inflammatory system. Now, it's interesting, and we have to say with Omicron, it's a watching brief, as it were, because Omicron's only around for 2 months. When do we see PIMS? It's usually in that sort of 6 to 8 weeks after somebody has had infection. We know that Omicron seems to be milder and that it doesn't invade the lower respiratory tract as much. So what we don't know is how that will translate in terms of its impact in generating that inflammatory system in children. There's a little bit of cautious optimism that it mightn't do it as much as, for example, the Delta. And we certainly saw the impact of Delta because just after Christmas, there certainly was an uptick in the number of children being admitted to our hospitals with the inflammatory syndrome, but that reflected the Delta's infections from the November time and the early December time. So children are certainly impacted. They are potentially affected by the virus directly, but rarely. They're affected by the consequences of the virus, and we've talked about the inflammatory syndrome, and we don't know that much as yet about long COVID in children, but they have been hugely impacted in so many other ways in terms of their overall normal childhood, socialization, psychological effects, anxiety, and that really has spanned all the age groups, because even in toddlers, even in infants where you say, oh, well, it's not going to affect them, but they haven't had the normal socialization that babies born outside of COVID have had. So there've been huge impacts across the board on children.
I suppose one other thing you spoke about at the first event was the lack of ICU beds and the need for kind of more isolation units in hospitals in Ireland. And you mentioned long COVID there, but like say mixture of long COVID perhaps putting more pressure on our system, and also perhaps new mutants or new variants coming on stream. Like what do you think the health service is going to handle now, or has it adapted?
Well, I think COVID, while it has brought out a huge amount of good in the sense of collaborative work across different pillars of our healthcare system that maybe previously haven't worked as tightly together, COVID has really cemented a lot of those relationships and interactions, but it has also highlighted a lot of our deficiencies. And that really comes into our health infrastructure system in terms of the actual physical bricks and mortar, because having long wards with many beds in it, inability to safely, not even isolate, because isolate can, could suggest putting someone away from everything, but being able to keep someone safely distanced from other people when they're in hospital, that has been challenged. It's also highlighted, apart from that, how we're on a knife edge in the healthcare system, always in terms of our actual human resources on the front line. And that spanned not just the hospital situation, and David can speak more to this, but in the primary care, because we saw how, for many people, there weren't the backup supports there, and there was an undue burden placed on them. When you think of how primary care responded to the vaccination need, it was absolutely fantastic, but at a huge personal cost in terms of hours and in terms of the other health issues that have been delayed. And you do worry that there is that slight tsunami of undiagnosed or deferred diagnosis waiting for us. So I saw, as I was mentioning before in the paper, there's a convening of, as it were, a post-action review to look at this and to get the learnings from COVID. And it will be really important to try and put the infrastructure in that's needed and put the supports. And the other thing was the agility of the system, because we can't always have everything ready for a COVID within hours, but we need to know how we can get it up running and quickly. We can't keep it all working, but we need to know how to get it in place very quickly. So those things have certainly been highlighted over the last year.
David, I might bring you in there on the impact in terms of primary care. Like even yesterday, I went to go to my pharmacy and they closed early because of short staff. So it's impacting health across the board. But in terms of impacts, maybe you can talk about the impact on primary care, but also the impact on students, because last year you did speak about impacts on mental health and related to isolation and not being able to interact with peers. So perhaps you can talk about that.
Yeah, that has very much continued, and we now have quite a lot of data on that. Particularly, so overall hospital admissions for mental illness in the 18 to 44 age group increased by over 20% in the last year. But specifically in the age cohort of 18 to 24, there's been a massive increase in hospital admissions for mental illness, but in particular related to eating disorders. That's definitely been the biggest rise. And that's really mirrored what we've seen in primary care. So our GP services and our college psychiatry service have just seen a very significant increase in eating disorders. And the other thing that we've noticed, and that's also been mirrored in the hospitalizations, is the increase in eating disorders in young men. So young men previously formed a much lower proportion of admissions to hospital or presentations to primary care with significant eating disorders. But in the past 18 months, they've comprised 40% of admissions with eating disorders. So that's quite a change. So I suppose one of the things we really noticed clinically was the impact of isolation. We noticed it particularly among international students who had come to Dublin and maybe didn't have the infrastructure, family networks, or peer groups or friend groups. They were often living in non-campus accommodation, so they were living in private rented accommodation, and many of those ended up presenting to us over a period of a few months, over a period of several months, and often these students would have lectures online, but actually wouldn't see a person face to face, maybe for several days. Many of them were extremely nervous about going outside at all, at times when we were within one of our 3 or 4 waves. And what struck us when we spoke to them was often they would be going out at night, late at night, to do their shopping, so that they would meet less people, and that meant then they had less human interaction. So that was really very problematic, I think. But I think another issue that's coming down the line for us clearly in primary care is the delayed diagnosis, because although GPs have been asked to pivot several times during the pandemic, there's no doubt that by having a lot of consultations online or by telephone, patients who might just have dropped in or come in for a routine consultation, GPs know that many of their consultations, when a patient presents with a particular problem, it's quite different to hospital outpatients. When patients come into general practice, they often come in and they present with a specific problem: cough, sore throat, tired all the time, whatever it is. But often in exploring that issue, and maybe only at the very end of the consultation in a throwaway remark, the real reason for the presentation appears. And that can take maybe 5, 10, 20 minutes, half an hour to create a situation where the patient is happy to bring that forward. And I think a lot of that has been lost in the type of online system, getting a repeat prescription just directly through really without any human interaction. That, I mean, don't get me wrong, and Karina alluded to it there, the infrastructure changes around, and also the legislative changes around prescribing have been really fantastic for GPs, for pharmacists, but particularly for patients. We were in the University Health Service here, but a huge proportion of our patients, probably 80% of our patients, were living a long way from our practice for most of last year, many of them living down the country. But still they were able to phone us for repeat prescriptions, and we could have their prescription in their pharmacy by the time they would walk down to it. And that pharmacy could be in Sligo or Letterkenny or Kerry or wherever. And that was a huge advantage for patients. But I do think that it is an issue. It will be presented as an issue around delayed diagnosis. We know that with screening programs have been, had to be put into abeyance or delayed or and I think there's an inevitability around that.
And thanks, David. And I'm just looking at some of the questions coming in, and one is related to something I was going to ask you, Cillian. So one thing that has led to the opening up of society has been a change in the severity of disease in the new Omicron variant. And I remember last year an audience member asked, they were struck by something you said in the first talk, that viruses mutate and they often become something that we can live with. And I suppose my question was, has it now become something we can live with? And if so, will it stay that way? And it's kind of linked to something that Keith Harrison just asked, is do you believe there'll be another mutation in the future? So what do you think about that? Have we a virus now we can live with?
So there's a couple of parts to that question. And I suppose just to answer Keith's question first, will there be other variants or mutations in COVID-19? Yes, is the short answer, almost certainly. Now, obviously, it's very difficult to predict the future, and it's a bit of a fool's errand in the context of a pandemic, but the virus will continue to evolve and continue to change. And the question is how that will have an effect on its virulence and pathogenicity and disease severity, as you mentioned there. But I think one of the messages to try and get across today is that Omicron in and of itself is not a mild infection. We are in the fortunate position that we're in the context of opening up or easing restrictions within our society purely in part because of the virus, but primarily because of the fact that our population is so vaccinated. If you look at other countries where the vaccine uptake has not been so great, Omicron is causing significant problems. So I don't think this in and of itself is a variant that we can choose to live with, but certainly we're potentially moving in the right direction because, as Nigel and Karina alluded to earlier, there's been a fundamental biological change in the behavior of this variant, which is very good news for us, but in many respects is probably just quite fortuitous. We don't really know why it has changed its behavior. It may be due to the impact of prior immunity or vaccines, or else it's just random chance, but it replicates very well in the upper airways. Its mode of entry into cells has actually changed and evolved, which means that it doesn't enter into lungs or lung cells quite as well. So there's an attractive narrative there that suggests it doesn't cause as much severe disease because it's not causing damage to the lungs, whereas it's far more transmissible because it replicates very well in the upper airways and in nasal epithelium. The problem with that narrative is that Omicron emerged in the middle of 2020. So we don't know where it's been for the last 18 months. It's either been circulating in immunocompromised individuals and evolving in that setting, in the setting of a suboptimal immune response. It's been in an animal reservoir and has been acquiring the mutations that Nigel alluded to earlier, or it's been circulating in a part of the globe that didn't have very good sequencing surveillance programs in place. The last of those is probably very unlikely, but how it emerged, we don't know. So the evolutionary narrative of the disease getting milder would be very nice and attractive if Omicron had evolved from Delta, but it didn't. It evolved probably around the same time as Delta, if not before. So therefore, we don't yet know what's driving this evolutionary journey. And then the other piece of information, if we look at all of our other seasonal human coronaviruses, they have all turned out to be viruses with which we can live, where children are probably infected multiple times in childhood and they get a level of protection and we get a level of population level immunity. So will SARS-CoV-2 ultimately end up there? Based on the evidence we have, it probably will. The problem is we don't know how long that journey and that pathway is going to take. It could be 5 years, could be 10 years, could be 30 years. We've interfered with that progression through vaccination, which obviously we had to do to protect people. We will interfere again with antivirals, and we will interfere, we've interfered with intensive care and dexamethasone and all those other therapeutic agents that we have, and monoclonal antibodies. So they'll all impact on this journey, on this sort of move to an equilibrium between the virus and its new host. But is Omicron at the beginning of the end, or is it the end of the beginning? And I don't know the answer to that yet. It's certainly, we're in a better place because of it, but we're also in a better place because of our vaccine uptake. And I think it's like the old sort of sporting adage, the more I practice, the luckier I get. Well, if we got fortunate with Omicron, the more we vaccinated, the luckier we got.
Yeah, and I suppose just speaking of treatments and research, Nigel, you spoke about the large amount of COVID work being done, including by Irish researchers. So I was wondering if we've learned more in terms of treating and understanding the infection over the past year.
Yeah, absolutely. Over the past year and over the past 2 years, there's been a huge amount of research. And it's really propelled scientific research as well, and understanding of viruses. Of course, my group are the viral immunology lab, and we always believed viruses were very important. But now the world is focused on viral infection, which is, of course, wonderful for viral immunology. Our lab continued to focus on how these coronaviruses target innate immunity, or the immune system that is there immediately when viruses infect our bodies. And if you get infected with any virus, you start producing this molecule called interferon, which is one of the main things that we work on in our lab. And interferon is basically our natural antiviral drug. It induces hundreds of antiviral genes, and these target viruses in numerous ways. And generally, this is the way we clear viral infection. But of course, we know not all viruses are cleared, and that's what my lab are working on. And we've discovered that all the deadly coronaviruses, SARS-1, MERS, and now SARS-2, target this interferon response. And we've identified a conserved region within these 3 viruses and within other viruses that we previously looked at. And we're now focusing on whether or not we could be developing prototype therapeutics that could target this region that's conserved across these viruses. And the fact that this region is within all the deadly coronaviruses that have emerged, we're hoping that maybe this will be a region that we could identify in future emergent viruses. And as Cillian, as we've all said, there will be future emergent viruses, and that is the thing that we can definitely say is definitely going to happen. So I think we have to prepare for those, and I think research needs to be thinking about that as well. Of course, we're firefighting SARS-2, and we're trying to work out how to stop people getting infected, how to treat it, how to develop vaccines, how to make sure everybody's vaccinated. All of those things are really important. But at some point, we're going to have to think about the future as well.
Perfect. And I suppose just speaking of the future, one of the issues that has been identified has been vaccine equity, to try and roll out the vaccines across the world in order to prevent perhaps new variants. And Karina, obviously you know a huge amount of vaccines, being the chair about the National Immunisation Advisory Council. And as you mentioned before, there's been a huge uptake in adults in terms of vaccines, and perhaps a lower uptake in children, but it's early days. But I suppose it was reported at the weekend that 100,000 vaccines expired last week, and another 500,000 are set to expire in the coming fortnight. And I was just wondering, how can that be justified given the huge amount of people around the world who have still not received their first dose? So yeah, if you can comment on that and vaccine equity.
Well, I suppose the issue, and we've been very conscious of vaccine equity throughout. And one of the questions in that is always to ask, are vaccines needed before you use them? And that was something that very much informed, if you like, the booster campaign throughout, because it was evident in the beginning that we needed the primary series of vaccination. And I suppose the reality was there was hope that the immunity from that primary series would last longer, and that there might be possibility of delaying any need for a booster dose. But it became evident towards the end of the summer to the September, coincident really with the emergence of the Delta variant, that the level of protection that was afforded by the 2 doses of vaccine was not enough to achieve the vaccine's goal. And that we have to think about what the vaccine goal was, which was to protect against severe disease and death and hospitalization. And so it was in that context and conscious of the need, and I'm glad to say the country was able to divert some vaccines that were already in the country to other countries, and to stop the ordering of some vaccines to allow, in that period when we were all well protected, to allow a more equitable distribution. But as the Delta variant really took hold, really the health of people was seriously threatened, first evident in the elderly, but across the ages. And that informed the booster program. And we knew for everybody's good that there was a real need to use those vaccines. At the same time, the arrangements were being made, and the country was part of the COVAX initiative and donating vaccines on the wider scale. It's not always as simple as taking a vaccine that's not going to be used here and sending it to another country. That can't happen that simply, because obviously there's whole logistical issues, safety of the vaccines, proper transfer of the vaccines, all of that. In terms of the vaccines that are now expiring, it was anticipated that that would be the amount that was needed for those who were due the boosters. And the uptake in the boosters has been somewhat slower, and particularly in the younger age groups, because I think there was a narrative that crept in. It's okay, it's mild, we can get it, it doesn't matter. But first of all, we've heard Cillian talk about Omicron and that it's not always as mild as it might be, but also vaccination and the boosters, it's not just about Omicron. It's about keeping that level of protection up against coronaviruses and whatever variant might arise. And what has been fantastic about all of the vaccines, while they don't protect about necessarily getting infection very strong, and we wouldn't expect them to do it, they have been very good at protecting against serious disease, hospitalization, ICU admission. And we see that in the data, because although we have had people hospitalized and admitted to ICU, we know that for the most part, those who are unvaccinated are hugely overrepresented in ICU and in hospitalization. And for many of the others, for some of them in hospital, they are picked up with having coronavirus because they're in hospital, or they might have picked it up in there, but that's not the prime reason that they're in hospital. So the vaccines have been very effective in what they are aimed to do, but they do need to keep up that level of protection. And one of, if you like, we have to acknowledge the disappointing things, is that the immunity has drifted down over time, and more so against the variants like Delta and the Omicron variant.
Thanks, Karina. So we have 15 minutes left, so we'll move on to questions. So if you want to get any more questions in, just put them in the Q&A. So one of the questions that Robert Vaughan has asked is, there's a small narrative flying around of my next booster dose will be catching Omicron. And now that things are reopening, there is more of a likelihood to catch this variant. So what is the panel's views of this herd immunity mindset?
I'm happy to start on that, and Cillian and others will want to come in. But there's no doubt that population level immunity is going to be important for us in terms of returning to a new normal. And we can ask the question of what's the new normal. I'll come back to that because I think it's an interesting question. But population level immunity, and we have to recognize that immunity is given, if you like, or conferred in two ways, both from vaccination and from infection. And actually what has transpired while in the early days, it seemed that the vaccines actually gave a higher level of protection than the first levels of infection, that combination of where you've had infection and then you get vaccinated, you actually get a very broad breadth of protection. So in effect, having Omicron, if you become infected with Omicron, that does boost your immune system further and acts like it's another exposure to the antigens that stimulate your immune system. Now, there are some who argue still that you still need to immediately follow with your vaccine, but we certainly would allow a period of time elapse before doing that. But yes, it is another exposure to the antigens, and it does boost your immunity, and you have a level of immunity that persists. But we also know that after natural infection, as after the vaccines, immunity does dwindle over time. And what we don't know is how long that will be, even now after someone's had 2 doses of vaccine and then either gets Omicron or gets a booster dose, how long they will be protected. We know it's likely they will be protected for at least 4 to 5 months against serious infection, up to 8 months for serious infection, up to 8 months or longer, but we don't know whether in fact repeated stimuli to the immune system, i.e. repeated boosters, whether on an annual basis or an every 2-year basis, might be needed. I'm sure Cillian has views on this as well.
Yeah, no, thanks, Karina. I would agree with pretty much everything you said. I think again, if we look to our normal seasonal human coronaviruses, we know that the immunity, the protection against those, they cause the common cold. We know the protection against those doesn't necessarily last terribly long from an infection perspective, but equally we know that the majority of people don't get very sick. They don't cause a lot of severe disease or hospitalizations. So if that's ultimately where we're going to get to, then the more additional exposures to Omicron or SARS-CoV-2, whether it's through the antigens contained therein, whether it's through vaccination or natural infections, as Karina said, will be beneficial. I wouldn't be encouraging people to go out and have COVID parties. I don't think that's what we want to do at this stage. But I think our role as a society and as a health service was, once the virus became so transmissible that it was probable everybody would be infected at some point in time, the key for us was to make sure that when you got infected, you had been vaccinated first. And I think, thankfully, we've achieved that to a certain degree. And that's what I would encourage people to do, to get the vaccine. They are right. They may well still be infected naturally at some point, but their risk of severe disease is far less if they get vaccinated first, regardless of the variant.
I think if I can, just to come in and just to emphasize what Cillian's point there is that we don't encourage people to go out and have, as it were, COVID parties, because you have to remember, while you might not end up in ICU, even young people who've had 2 doses of vaccine and then who get COVID can be very unwell for a period of time. And we don't know all the long-term effects of this virus. So it absolutely is a bad idea to try and get it as your booster dose.
Perfect. Yeah, good point.
Maria, if I can say,
yeah.
Say about that as well, we're still not at the point. Omicron is still not just a bad cold, as I said earlier. It's a systemic infection. It affects more than just our nose and our throat. It potentially can affect lots of our organs as well. And as I mentioned, there were over 50 mutations in Omicron that we have identified, and there are lots of those proteins that make up the virus that target our immune response and target our other organs in our body that we don't understand yet. So if you can avoid getting Omicron, avoid it. This is not something you want to get.
All right, and I suppose just keeping on the track of health, David, I might bring you in on this one. And the next question is, how much is the mental health crisis playing into how we decide to manage this virus now? and how can we be better prepared for this? And I suppose maybe just given the lifting of most restrictions at the weekend, like, do you think that maybe played a role in that, or maybe you can talk about the mental health side?
Yeah, I suppose our day-to-day experience for the last, particularly during the peaks of each wave, was looking at the daily case numbers and the hospitalizations and ICU admissions, and then the deaths, of course, and particularly I think in, from January to March or April of 2021, when we had that absolutely huge number of deaths. And I think we really have to think of all those people. Like we had 3,000 deaths in that very short period of time. It's just when you talk about, lifting restrictions, the implications of these decisions were so dramatic and so serious. And I really feel for the people who had to make decisions as well. I think that's really important. All the people on all those groups all the acronyms that we have, whether they were NEFIT or the HSE or NIAC, I mean, the strain and the pressure on the people working in those groups, and there are people on this call on them, every decision they made was they made it in a clinical context, and then the government had even more difficult decisions because they were trying to make those in the context of running the country and keeping the country going and everything like that. So to go back to the mental health, I think we were very focused on the physical health, particularly through the waves, because it really governed our own independence in terms of whether we could leave our home or 5 kilometers or leave our county or whatever. We've forgotten all that already, I think, very quickly. But throughout that time, there was clearly a mental health crisis brewing, and we know we've seen it particularly in the areas that I spoke about earlier around eating disorders, but also around the increases in case numbers, particularly in young people or young adults, of ADHD. That's a really good example of a strain on the mental health services. With the criteria of the criteria for diagnosis of ADHD being, previously that diagnosis was not made in people over 18, and over the last few years that condition moving into the adult age group, because clearly when people became 18, it didn't disappear. But previously, we didn't have that diagnosis in the older adults, and now there are more and more people coming looking for, wondering whether that is their diagnosis, which meant that services had to be put in place for those. And around the country, services were not in place, and they're gradually being put in place. But overarching in the mental health field, I mean, we had a document, Vision for Change, in 2006. Many of you will know it. It was a very aspirational document. It clearly did not deliver. And it has now been replaced by another aspirational document called Sharing the Vision, which has all the magnificent aspirations in it. And really, it's going to come down to implementation, of this. I would say pre-COVID-19, one of the things we really suffered from was what one of my colleagues in UCC and Student Health, Michael Byrne, calls IDD, implementation deficiency disorder. We're brilliant at writing reports, and we're brilliant at, we can put all this out, but it's actually the implementation. Now, what COVID did to me, I think it really showed that we could implement things in a crisis, massive interdisciplinary working, cross-cutting, medicine, nursing, politics, all social groups. We were able to implement what we needed to do. Look at the vaccination program, look at the testing. We were able to implement these huge changes. We can do it if there's the political and financial will to do it. The document is there to do that, to make those changes, but really it's going to be around the implementation.
Thanks, David. I just ask one more question because we're coming up to 5 to now. And it's kind of a good one to finish on for our final coronavirus series, I think, is how has this pandemic prepared us for the next one, possibly a more severe one? Hopefully that won't happen. But Cillian, maybe I'll bring you in, and then if anyone else wants to come in after that.
Yeah, thanks, Maria. Dave touched on some of the issues there about the infrastructures that are in place. Hopefully, I think we've learned a lot of lessons from this pandemic. Speaking, I suppose, from my own area, the laboratory infrastructure required to test the number of samples that we've ended up testing wasn't there. On the laboratory side, we obviously didn't have the community testing facilities or the sampling facilities. So I think what we need to do, and we have been quite fortunate to a degree in some respects, that the overall case fatality rate for SARS-CoV-2 has been quite low. Like if we look to, I suppose, the worst case scenario, something like an avian influenza H5N1, the mortality rate for that is about 50%. The mortality rate for MERS is about 35%. But thankfully, neither of them has become terribly transmissible. But if they were to evolve and, recombine with something else or reassort in the case of influenza, then that would be a real concern for us. So I think the problem that we have at the moment now is, as David has alluded to, in some respects, I think the HSE is an excellent sort of firefighting organization, and very good in a crisis. What we need to do now is make sure that we have the structures in place for the next pandemic, right through from the sampling side in the community through to the laboratory side and through to the hospitals, because the sad fact is that, notwithstanding the last 2 years, we have no real additional hospital-based infrastructure. We have no real additional, single isolation rooms. We've no new hospital beds. Things have been moved around a little bit, and there have been temporary measures put in place. But really our big concern, the other thing is that we don't have an individual health identifier. So our data flows were really challenged through the course of this pandemic. We had to set up lots of different IT systems and teach them all to talk to each other. Whereas if you look at the NHS in the UK, they've had phenomenal data because they could track somebody right from their infection through to their vaccination, through to all of those other things, and they all came together. So that's one of the things that I'd like to see on the IT side. We don't have a national laboratory information system, which has been in the planning stages for a long time. So I think we've learned a lot. But it comes back to David's point: how short will our memories be, and how quickly will we move to, pandemic preparedness has been a thing, to be honest, since before 2009 when we had our influenza pandemic. But it's always been this sort of nebulous concept of just, putting things in place. And I think a lot of those systems were challenged in the course of this pandemic. And what we need to do is have a pathway in place that doesn't knock our routine health services, because, as soon as the restrictions lifted last Friday, the conversation in the media switched to the waiting lists. Understandably, there's now 1 million people or something on waiting lists. So we've significant problems outside of the pandemic. So we need to try and balance the two interests. But I think we've learned a lot, and hopefully we'll be able to put in place a better structure in advance of the next one.
Perfect. We only have a minute left, but Karina, I don't know if you want to.
Yeah, I think, everything Cillian says, I wouldn't disagree with anything. But I think one of the things that we need to recognize is the importance of the public health infrastructure, and that had been hugely depleted and beginning to be strengthened, but that is really critical importance. The absolute importance of an IT system like Cillian, the fact that we have to continuously, for a lot of things, look to the UK and the world has, not just Ireland, emerging data in Scotland because of their ability to link the linkages. And we so need a unique person identifier number that can be used appropriately for public health means. So they were one thing. The importance of surveillance, and that applies not just to COVID, but in terms of respiratory surveillance, because that's going to be where probably the next pandemic is going to come from, whether it's a coronavirus or a flu or an avian flu or whatever. So ongoing surveillance, and be that whether it brings in the wastewater as well. And that applies to other conditions as well. And recognizing that vaccination is not just about a childhood program, it really is cradle to grave, and the importance of vaccination, this is highlighted to us, and keeping that to the forefront as well, because that's really important. So they're just some of the things. We could go through lists of the learnings, but I'm glad to see that people will be focusing on what those learnings on, and hopefully then again that we don't run into, and I love it, the IDD, doing the report but not translating the report into action.
Perfect. No, thanks so much. And unfortunately, we've run out of time for this final coronavirus panel. So I just, before we go, I'd like to thank Dr. Cillian de Gascun, Dr. Karina Butler, Dr. Nigel Stevenson, and Dr. David McGrath. And thank you so much for joining us on this panel. And unfortunately, one of the final Science Gallery events.